The last learning objective is given a patient living with HIV who is infected with an opportunistic infection, recommend guideline-concordant treatment. So for PCP treatment, obviously it's important to start the patient on ART to get the CD4 count up. And then for the actual treatment of PCP, you have to look at the severity. So for mild to moderate, and the criteria are listed here for mild to moderate, you typically use an oral treatment. And again, treatment of choice is Bactrim, so trimsulfa, 15 to 20 milligram. And this dosing is based on the trimethoprim component. So when we say 15 to 20 milligram per kilo per day, that's basically trimethoprim, and then whatever sulfamethoxazole to match it when it comes in the pill. And that's, when you calculate 15 to 20 milligram per day, that's the total daily dose. You want to break it into 3 divided doses. And then you treat the patient for 21 days. And obviously, if they cannot tolerate trimsulfa, you have some alternatives. So dapsone plus trimethoprim, because the sulfamethoxazole typically causes the skin reaction. So if someone cannot tolerate that part, it can also be nephrotoxic. You can give the trimethoprim alone with dapsone. You also have primaquine plus clindamycin. And lastly, atovaquone. So atovaquone for prophylaxis is okay, but when it comes to treatment, is an absolute last line, because it has been shown in studies to be less effective. So you really want to avoid atovaquone for treatment if you can. It's only your last option. And then when it comes to moderate to severe, you obviously want to, if you can, you should use IV treatment. So Bactrim is available as IV, so you can use IV Bactrim. If someone cannot tolerate IV Bactrim, then you have some alternatives. Primaquine obviously is only available as oral, so you have no choice but to give it oral if someone couldn't tolerate pentamidine IV or Bactrim. And for these patients who either the PO2 is less than 70 or the gradient is more than 35, so alveolar and arterial oxygen gradient is greater than 35, these patients also need prednisone. So this is adjunctive. So in addition to what you're giving for treatment, so if you're giving Bactrim, these patients, in addition, they also need prednisone for 21 days. And here's the dosing taper recommendation. And that's because this addition of prednisone has been shown to reduce mortality. So for that reason, someone has moderate to severe PCP, you have to give them prednisone. Or if prednisone is not available, you do an equivalent corticosteroid. And then once you finish treatment, the question is, do you need to prevent this from happening again? So there is such thing as PCP secondary prophylaxis. So you basically give the same agents we use for primary prophylaxis, and you continue it until the CD4 count is greater than 200 for at least 3 months. For Toxoplasma gondii encephalitis, the treatment is a combination of pyrimethamine, sulfadiazine, and leucovorin. That's the preferred agent. And you want to treat for at least 6 weeks. So this is a 6-week treatment. And even longer duration if clinical or radiologic disease is extensive or response is incomplete at 6 weeks. So you have to monitor the patient through the 6 weeks and see how they're improving. And then once you finish the treatment, you just continue the same treatment as chronic maintenance therapy, or you can also call this secondary prophylaxis. You just keep continuing the treatment until the patient, not only asymptomatic, but you want to make sure the CD4 is more than 200 for at least 6 months. And for disseminated MAC, basically the preferred agent for treatment is combination of clarithromycin with ethambutol. We will discuss ethambutol more when we talk about tuberculosis, but you want at least 2 agents. And many experts also add a third or fourth agent if the mycobacterial load is more than 2 log CFU per ml of blood, or if the patient is not on ART, so you need a third or a fourth agent. And the third and a fourth agent would be rifabutin. This RFB is the shorthand for rifabutin. And you can also use fluoroquinolones, specifically levofloxacin or moxifloxacin, not ciprofloxacin. You can also have the option to use an injectable aminoglycoside. So amikacin and streptomycins are the ones that are typically used, not really gentamicin or tobramycin. The evidence is with amikacin or streptomycin. And then the treatment for MAC is at least 12 months. And then once you finish treatment, you just continue for secondary prophylaxis, or you can call it chronic maintenance therapy, until not only the patient is asymptomatic, but you want to make sure the CD4 is greater than 100 for at least 6 months. Because retinitis is the most common CMV disease, we will focus on managing CMV retinitis. The choice of therapy should be individualized based on tolerance of systemic medications, prior exposure to anti-CMV drugs, as well as on location of lesions in the eye. For example, someone who has been receiving valganciclovir, they may have developed resistance to cyclovir and valganciclovir, so they may need cidofovir or foscarnet. Now, systemic therapy, either IV or PO, systemic as opposed to intravitreous injection, has been shown to reduce CMV involvement of the contralateral eye, to reduce CMV visceral disease, as well as to improve survival. So the first line therapy includes either IV ganciclovir or PO ganciclovir. Many clinicians prefer the IV formulation when retinitis is more central and sight threatening, or when adequate GI absorption is a concern, so PO cannot be an option. On the other hand, for patients without sight-threatening lesions, oral valganciclovir alone often is adequate. Now, initially, there will be induction therapy, which would last for a minimum of 14 to 21 days, and there is a range, and that will be determined by clinical response based on ophthalmologic examination. And then this will be followed by a maintenance therapy. So during induction therapy, we give a higher doses of these, either ganciclovir or valganciclovir. So it will be higher doses during induction therapy. And then for maintenance therapy, there will be lower doses. And obviously, the primary concern with the high dose during induction therapy would be myelosuppression caused by these agents. And then the maintenance therapy will continue for 3 to 6 months until these patients, while they're taking their ART, they should be able to achieve a CD4 count of at least 100 for 3 to 6 months. And once the lesions are inactive, then maintenance therapy can be discontinued. On the other hand, if the patient's CD4 goes below 100, once somebody has developed CMV retinitis after completion of therapy, if their CD4 goes to less than 100, then chronic maintenance therapy should be reinstituted. Now, alternative therapies include IV foscarnet or IV cidofovir. It's very rare to use IV cidofovir because of the complications of dosing and managing nephrotoxicity. For patients that toxicity of ganciclovir or valganciclovir of myelosuppression is a concern, and if those patients do not have renal insufficiency, or if somebody has ganciclovir resistant CMV, for those patients, IV foscarnet may be used. Now, for patients who have sight-threatening lesions, In addition to systemic therapy, it's recommended to also add, in addition, adjunctive intravitreous weekly injections of either ganciclovir or foscarnet in order to achieve enough of the drug, adequate concentrations of the drug in the eyes. So these are the possibilities. So the preferred therapy includes either IV ganciclovir high dose twice a day for the induction therapy of 14 to 21 days, and then switching to a lower, once a day dosing of IV ganciclovir for maintenance therapy. Alternatively, we can do just the induction therapy of IV ganciclovir and then switching to oral valganciclovir for the maintenance therapy, or for mild cases without sight-threatening lesions, the entire regimen could be oral. So twice a day dosing of oral valganciclovir for induction therapy, and then switching to once a day dosing for maintenance therapy. And at any time, regardless of which regimen is used, IV ganciclovir can be switched to oral valganciclovir as long as the patient is clinically improving and there are no concerns about GI absorption. For example, if somebody also have CMV colitis. Now, alternative therapies are listed here, foscarnet and cidofovir. You can see that, cidofovir is very, very difficult, so it's, very rarely used. It's hard to find, people who would need cidofovir, because in cases of resistance, foscarnet would be an option. Now, treatment of other complications of CMV, such as colitis, are similar to retinitis. Obviously, there will be no intravitreous injection for other CMV diseases. This concludes this presentation.